Ukrainians. Dear colleagues, we are going to continue with the ophthalmological care in the conditions of the full-scale invasion, the experience of the National Military Medical Clinical Center, the Chief Military Clinical Hospital from Kiev. Please, we kindly invite Bohdan Zhupan, head of the Clinic of Ophthalmology of the National Military Medical Clinical Center, the Chief Ophthalmologist of Armed Forces of Ukraine, ophthalmological surgeon, Doctor of Medical Sciences, Associate Professor of the Department of Military Medicine, and also Honored Doctor of Ukraine and Colonel of the Medical Service. Please, Bohdan, the next 20 minutes are after you. Good afternoon, dear colleagues, friends. I have this honor right now to present the experience of the ophthalmology care in the military conditions. But before starting my presentation, I would like to show you a short video about the combat medics, and just to get back us to those times which we had in the past, the dark times. Please, kindly ask you to get the video on. Please, the video. Thanks so much. Thanks to all the combat medics. We need to remember that on the 24th of February at 4:30 in the morning, there was a full-scale invasion of the Russian Federation on the territory of our country. 9 directions from Belarus, Russia, and temporarily occupied territories of Ukraine, and also the Black Sea. The offense started from the shelling of the military objects and also the objects of the which was civil. Also, there was shelling which were happening in 50 kilometers from the border of the European Union. There was more than 100,000 people in the army of the Russian during the offense. I'm going to remind you that the war started not in 2022, but in 2014 after the occupation of Crimea Peninsula and also the Donetsk and Lugansk region. Starting from the first days of this offense, not only armed forces of Ukraine faced challenges, but also the civil population of Ukraine, even in the remote areas because of the shelling. We have faced different kind of weapons which were used in this armed conflict with different kinetic energy mechanisms, with high kinetic energy. There was used the ballistic rockets, but also then we have more mortarage and UAP. And there is a huge increased usage of UAV, of different kind of like kamikaze drones and also drones. The structural damage to the organ of vision is made by the different factors, a couple factors: shockwave, multiple fragments, thermal, chemical factors, and also the primary infection of the wounds in the place of trauma. The structure of injuries in the war casualties, it was changed with time. During the Second World War, for example, comparing the experience which we had in Afghanistan during the Soviet Union times and World War II and Russian invasion of Ukraine, the amount of injuries to the vision organs was changed. 2.2% in World War II and 4.6 during the full-scale invasion. The usage of the modern protection measures like the plate carriers decreased the amount of injuries of thoracic and abdominal cavity according to the data which we have, but at the same period of time the limbs which are not covered, the incidence of those traumas is increased, and also we have increased amount of traumas to the head despite the usage of the modern Kevlar helmets, and also there is an increased amount of eyeball trauma. That's the issue which is associated with not using the tactical glasses. According to the different authors, the usage of the tactical combat oculars or glasses is not higher than 30%. According to our experience in our center, we have 48% which are associated with contusions or closed globe trauma of a severe and moderate severe stage. Regarding the penetrating wounds, we have the intraocular foreign bodies in 30%. Orbit trauma without the damage to the eye vision was not included in these statistics. At this moment of time, there are 4-step system of evacuation and treatment. The same system is used according to the NATO countries. The primary health care services are provided in stabilization places on the row 1. On the row 2, that's the medical services in the mobile hospitals. The qualified medical assistance and care is provided, and also specialized ophthalmological care is provided on row 4 and row 3. During the providing the medical health care, especially in the row 2 on the second stage, we need to use the next principles of time, principles of inheritance, and principle of care and continuity of care. The care is provided by the general practice specialists and surgeons for whom we have this algorithm of action is developed. In case there is an interest, I'm going to give more details on it later on. Because it's quite close to the place of the battlefield, the evacuation is happening just with car vehicles, because the other type of evacuation is more risky. The evacuation on row 3 and 4 is used by the trains and also the military air facilities as well with the modern services. According to the existing LES system, the provision of specialist ophthalmological care begins with row 3, because in order to implement it, we need to have the criteria and environment which is shown in this slide. In the beginning of the full-scale invasion, the enemy was stopped in 10-15 kilometers from the border of Kiev city, and the enemy was getting closer to our institution, 20-25 kilometers, which made us to optimize the LES system according to the tactical and combat situation. From the territorial view, we were in the second row of LES, but because of limitations, we have changed the structure in providing the surgical care during the first months of war. From February up to the end of 2022, most of the surgical interventions were the primary surgical care. Starting from the April of 2022 and having the evacuation being available, we have got to the specialized row 4 ophthalmological care. During this period of time, the most surgical interventions were the vitrectomies and also reconstructive surgeries. So these are the examples of the most severe interventions during the eye trauma. So the terms to get the patients on the row 3 and 4, it depends on the combat situation, the severity of the trauma, and also the vital functions of the patient. And it might be from a couple of hours to a couple of days. Because the ophthalmological trauma is not associated as life-threatening, the highly specialized ophthalmological care might be determined and delayed, and the emergency care in case of the vision trauma is provided in the nearest period of time. To get a patient on the row 3 or row 4 in case there is ophthalmological trauma with infection wound, with infectionated wound, it made us to delay the surgical interventions. The severity of trauma determines the need to have a stage-by-stage treatment with recurrent surgical interventions. For example, to change the tamponade medium, reconstructive surgeries, and so on and so on, in special cases when patients have one eye especially. Our approach is fully aligned with Professor Robert Masoli's approach, which he has presented in damage control ophthalmology and in zones. And right now we have this doctrine, the principle of uniform medical space, which is based on the cooperation between the civil and military institutions. And on this map, you may see the institutions with highly specialized ophthalmological care on the level of role 3. The severity to provide care in the pre-surgery approach, the long-term treatment need, the long term of surgery and also the post-surgery rehabilitation is based on the severity of the trauma. Quite important are the infection complications and proliferative complications which might appear, and also the atrophic changes in the eyeball. In case of the huge trauma, with the presence of the foreign bodies, the contusions with involvement of the outer membranes, the prognosis for the vision is not always optimal or positive. But even in case getting the vision back, some kind of changes might be because of the atrophy in the future. But in most of the cases, our work, it brings positive results and fruitful results and outcomes, which allows us to get most of our patients back to the service. Challenges of the war and the wish to improve the outcomes of treatment made us to conduct a scientific conference regarding the military trauma of the vision organs, where we had the civil and military ophthalmologists in Ukraine, and we had also representatives from other countries like United States of America, and we started to collaborate to develop the experience exchange, to have practical approaches and to establish the needed standards how to provide the care in case of the ophthalmological trauma, also the vitreous surgery, oculoplastic surgery, and so on. Starting from the full-scale invasion of Russian Federation into Ukraine, changes in logistics, approaching an offense to the Kiev, we have faced the increased need to have more medication, better equipment, more disposable materials, and more highly specialized care. We would like to say thanks to our colleagues, to our volunteers, representatives of pharmaceutical companies, and international partners for having a highly specialized care in this fight for the independence of Ukraine and fighting for the principles of democracy in the whole world. On behalf of myself and each citizen, the armed forces of Ukraine, I would like to say thanks for the support which you have provided. Glory to Ukraine, glory to heroes. Dear Bohdan, let me also say huge thanks for this great work. Help us, God, not to talk about those kind of challenges, but thanks a lot to all of our partners and to you for us fighting those barriers and for us achieving the improved quality of life among those who were injured. Thanks so much. Are there any questions to Bohdan, please? Okay, thanks. Then, Bohdan, we kindly invite you to get into the